Good morning, everyone. So, in the spirit of trying to catch up with time, I'm going to start the next lecture, the next presentation. My name is Dr. Kabahug. I am from Baltimore. I'm with the Kennedy Krieger Institute. I am a physiatrist. I take care of people with spinal cord injuries. Today I'm going to talk to you about what spasticity is and how it can affect people with rare neuroimmune disorders. I have no disclosures except I borrowed some slides from the internet, which I made sure to acknowledge. The objectives today is first we're going to define what is spasticity, identify what triggers spasticity, and we're going to discuss an overview of treatment options for spasticity. Let's start with a few facts. It is a common secondary medical condition following a spinal cord injury, or in this case, a spinal cord disease or dysfunction. It is estimated that 1 year after you get a spinal cord injury, its prevalence is between 65 to 93%. So it's a big chunk of people that can get spasticity. Usually, the incidence is higher in those with cervical and upper thoracic injuries and those who have an incomplete spinal cord injury. And it's really more prevalent in those with incomplete tetraplegia. So let's go first with the definition. I promise you the next two slides are the only technical slides that I have. All right. So any medical student, this is the definition they're going to see about what spasticity is. When I was a medical student, this was my reaction to that definition. It did not make any sense. The reason why it did not make any sense because the velocity-dependent increase of your stretch reflex, it only captured just one part of spasticity. It was very limiting. It did not reflect what I would see in my patients. Now, in 2005, the Europeans came up with a more inclusive definition, which also still does not make exactly complete sense, but it made more sense to me at this point in time. So they said it's a disorder in sensory motor control resulting from an upper motor neuron lesion presenting as an intermittent or sustained involuntary activation of muscles. Now let me break down that definition for you. So the last part, I guess this is easy to understand. For those who have spasticity, you understand this. It's intermittent or sustained involuntary activation or contraction of muscles. Okay. It is a disorder in your sensory and motor control. You basically have no control over spasticity most of the time. What people don't quite really understand is what the hell is an upper motor neuron lesion. And I'm going to try to explain to the best of my capabilities today. All right, so this is a lovely picture of the brain and the spinal cord. Okay. Hold on. All right. So your your spinal cord can communicate to your muscles, okay? Now, this communication between the spinal cord and your muscles, that's your lower motor neuron. Okay, now to expand that, and some of you have Googled this might be a familiar picture to you guys. In that lower motor neuron, that's where your reflexes travel. That's where they live. It's in between your peripheral muscles. You've probably experienced when you went to the doctor's office, hammer time, reflex hitting, right? So they would put the hammer here, they would tap. The receptors in your muscles would sense that stretch, you would sense that tension. That information goes up to the back of your spinal cord, crosses through the spinal cord with the interneurons, the little wires there, and then it goes back out there and causes your muscles to contract. That's a typical reflex that you see. Okay, that's the reflex arc. Now, moving on, there's a communication between your brain and your spinal cord, okay? And that is what your upper motor neuron is. The upper motor neuron regulates the action here in the lower motor neuron. Think of it, it's like the fine-tuning switch on a radio or the dimmer switch of your lights. the intensity, the control, that's the responsibility of your upper motor neuron. The reflex action, things that you don't even need to think about, that's why it's called a reflex, that's lower motor neuron. Now, when you have a injury to your spinal cord, the connection between your upper motor neuron and your lower motor neuron is affected. So there is nothing to fine-tune the control of how much your reflex is going to act up. There's nothing that's going to modulate it. It's like everything is going to be static and you can't find your favorite radio station. So far, so good? All right. Okay, so check. Number 1. Right. So what are the manifestations of spasticity? Those highlighted in red are what we call positive symptoms. Now, clonus, hold on. So and a lot of you here might have clonus, or some of you here might have clonus. When you stretch your tendon, like the ankle, it results in a rhythmic contraction. And if you can see here, it's just going on like that consistently. Some of the people who have clonus, it can interfere with how you're positioned in the wheelchair or if you are walking. Now, spasms, and some of you may be very familiar with spasms, they're this involuntary contraction of your muscle, and they can be painful, and sometimes you have no control over it. It comes out of the blue. It can interfere with your sleep. It can interfere with your activity. Next is spastic co-contraction. So the easiest way I can describe this or explain this to you is like when you bend your biceps, right? When you bend your biceps, your triceps is quiet. It relaxes, so it lets the biceps do all the work. Now what happens is in spastic co-contractions, these two muscles, because the control is no longer there, they're just acting simultaneously. They're contracting. They're not giving way to each other. So it's just like, and you can't either do this or you can't do that. Okay? All right. Your reflexes are increased, and that I explained earlier. Sometimes just like being touched, some people will just jump, and then the reflexes, I always joke that this is a occupational hazard when I do the reflexes. If I'm not positioned correctly enough, I could get hit in the face, so you have to be careful about that. Now, spastic muscles, I like saying the spastic muscles, even though they're contracting and tense all the time, these are actually weak muscles because that normal control of these muscles, it's gone. So there's no coordination, it gets fatigued easily. And spasticity, because of all of this, can interfere with how you function. One thing that I did not put in this slide, and I guess a lot of you who are living with spasticity may be aware of, that it can affect your outlook in life, it can affect your mood, and in some people, stress can trigger their spasticity as well. All right. So I just wanted to share this picture with you. So in the clinic, you're going to be assessed for your tone. And if you look here, it's not really that bad. She just has a little catch when my resident was trying to spread the legs apart. So just a little catch, not so bad. But then, and a lot of the times, this is what we see in clinic. When we test patients in a relaxed position, it doesn't really act up. Okay, but then when I ask her to walk, you can see that right leg is kind of like swinging forward and she's trying to fight it. Okay, so this is just an illustration how spasticity can interfere with your daily activities. All right, so it can be disabling, as I mentioned earlier. It can cause physical impairment, pain, fatigue, poor sleep. If it's always tight and not relaxing, the muscles can end up shortening. It can impair sexual function, and it limits your ability to participate and do the things that you want in life. It can be something as simple as trying to feed yourself, or trying to dress up in the morning, or trying to access the remote control. But there is a dual nature of spasticity. It can be a friend. So sometimes, in some patients, they can trigger their spasticity to help them do a movement. For example, I have a patient who triggers his tone to help him transfer, to stand up, okay? Being too loosey-goosey at this point is not good if you're trying to do a function. Now, spasticity can also improve circulation because your muscle is pumping, so the blood is going to come up. It also protects against muscle atrophy. And my favorite function of spasticity, it can serve as an early warning device. Okay, why early warning device? Okay, sorry about that. Sometimes when there is something wrong with the body, for example, when you have a urinary tract infection, or God forbid, you have a wound that you weren't aware of, or you got a fracture, your tone will act up. You will have an increase in tone. Spasticity can be generalized. It can affect all upper, lower. It can be focal. I have some people who just have spasticity of just one muscle, or it can be multifocal, meaning like several muscles, but not the entire body. Okay, again, I alluded to these complications. It can affect positioning, hygiene, ADLs, contractures. Now, the evolution of spasticity. This is very important to understand. When you first get sick, when you first have your spinal cord dysfunction, the body goes into spinal shock. Basically, everything is gone, right? For those who've had some of you have been familiar with experienced this. There are no reflexes, no spasticity, no tone, no motor strength. But then over a period of time, whatever will come back will start coming back. Now, spasticity, the natural development is if you got your dysfunction at the level where you're most likely will develop a spasticity, the upper motor neuron I mentioned earlier, it will increase over time. It will increase over time, and then it will stabilize over time. That's the normal pattern. That's the normal evolution. But then, as I said, early warning device. If something is wrong and your spasticity increases and it is not relieved by the things I will talk about later, but if it's not relieved by making sure you don't have a UTI or stuff like that, then we have to look for an underlying medical condition. So again, spasticity can be a foe, but it can be a friend. Remember that dual nature of spasticity. All right, so common triggers. Bladder, bowel, skin, and everything else. Okay? Bladder, bowel, skin, everything else. Number one, bladder, the most common one. As I mentioned earlier, it could be a urinary tract infection. For those who have indwelling catheters, it could be something as simple as your catheter has been kinked. The more challenging ones are if you have stones. It's either we wait to pass, or if the stones are big enough, we have to send you to a urologist. Okay? So, next, bowel. I like saying this term. The poop is the root of all evil. Yes. A lot of you can understand that. All right. This is an x-ray of a patient with constipation. So in a normal person, it's really uncomfortable. If you're gassing, you really need to go. So can you imagine if you've had a spinal cord dysfunction, you really have to go, right? And because of that abnormal sensation, that can trigger an increase in spasticity. Now with skin, that's why this is important for those who have decreased or no sensation. You have to do regular skin checks. Something as simple as an ingrown toenail. This is dermatitis-associated maceration. It's just like a diaper rash. It's like too moist. It can trigger spasticity, so anything with the skin. Everything else. Now this is where it's challenging. So all of these triggers, the top three triggers I mentioned, bladder, bowel, skin, those are the three things I usually rule out first, and then I look for everything else. Okay? So everything else can be something as benign, not really benign, as simple as a fracture. If you see in this film, this is not my patient's x-ray, but he had a similar fracture. He comes to me in clinic, and the mom is worried that, why is his left foot more swollen than the right foot? Okay, normally if he just elevates the legs, the swelling would go down. And they can't remember why, if they did anything unusual. So two things run into my mind. Is it a fracture or is it a clot? I actually just ordered an x-ray because that's the first thing that's easiest to do in my clinic, and lo and behold, he did have a fracture right over there. Okay, and the thing is, because he is insensate, he can't recall or doesn't know what happened. So those are the things we have to watch out for. Everything else. All right, treatment of spasticity. Now, this is what I'd like to call a more inclusive a more inclusive approach to spasticity. A lot other providers, and we've been taught before in school that there is a stepwise approach to spasticity, but in practicing throughout these years, I've come to realize it's not just step one, step two, step three. It is step one plus two and three, or a combination of everything else. The integral part is goal setting, though. I listen to my patients. I ask them what are their goals for function. First, we establish how bad is the spasticity? Is it disabling? Is it interfering with your quality of life? Is it interfering with the ability of your caregiver to provide care for you? Then we take it from there. Okay? There are a whole lot of things that we can do to address spasticity, but the first thing, the most important thing, is that goal setting. And then the next thing I do, if it's like an unusual or unexpected increase in spasticity, I eliminate all of those triggers first, because I need to find out if it's something that can be fixed. Let's fix it. All right. Now, let's move that. So let's go to non-pharmacologic management. So these are the standard rehabilitation techniques. You do stretching, do splinting and casting. Positioning is also important. Remember the everything else that I mentioned earlier. Sometimes it's like having a wheelchair that you're not comfortable in or that needs to be readjusted. That can trigger spasticity, so you have to make sure that the wheelchair is good for your patient. For other thing also is like standing. Standing helps also with trying to decrease the tone, in decreasing the tone. And why? Because if we are, for example, if you have spastic legs and ankles, one of the best ways that we can provide chronic stretch is for our patient to stand. And that could be done through a stander, okay, or through a special wheelchair that stands, okay. And strength training. Now you might ask, why do you want to strengthen a muscle that is spastic? It is a good thing to strengthen spastic muscles. Most likely, your muscles, as I mentioned earlier, their muscles will be weak. And if we strengthen that, and if we retrain as much as possible those muscles, that can help improve the quality of life, ability to do ADLs, and decrease the tone. So again, it's not just one approach. It's all of these approaches combined. Okay. All right, so this is one of our patients who have been using a stander, a little kid. Now, let me just see. So we also do a lot, this is just to emphasize what Dr. Sadowski was talking about earlier. We do a lot of in our activity-based restorative therapy program, we do a lot of gait training. So for this guy, his tone is basically interfering with the ease with he's walking. Now, what we do is, like, he's here in a body weight supported, he's doing body weight supported gait training. So you can see he can focus on trying to do a proper repetitive movement pattern in walking. So that's one of the tools that we use. All right. Now, physical modalities. Cryotherapy, also known as cold. Ding! Why are you going to put cold in a spastic muscle? Won't you get spasms? That's one of the first things that I get asked. But cold for a short period of time can decrease the sensitivity of the receptors in your muscles that trigger your stretch reflex. Now, heat also helps. So with cryotherapy, with cold and heat, they only last for like a short period of time. Usually the effect is between 30 to 60 minutes. But it's always a good thing to incorporate this, because typically you could put cold or heat depending on your preferences. Some people respond more to cold. Most of the people I see, they like heat better. After you apply the cold or the heat, you can do stretching. It's easier for people to stretch after this application. You could also do electrical stimulation. So functional electrical stimulation is we stimulate the muscle, but we pair it with a movement pattern. I'll show a video later. We also do transcutaneous electrical nerve stimulation. So again, we use stimulation, but the reason for using the stimulation is that it decreases the sensitivity of the afferents, so that the tone will go down. And then other is like direct electrical stimulation to muscles. One caveat though with electrical stimulation, it's not just you put an electrode and shock it. It actually requires skilled physical therapists to do the adjustments, working with goals and what the function we want to facilitate. Okay. All right, so you've seen this guy earlier this morning. So he's doing, well, I could always run the video just so like to keep things interesting. If I can get the mouse to work or not. We'll skip that. You saw him bike cycling earlier. And this is a placement of transcutaneous electrical stimulation. So, all right. Other therapeutic options, vibration plates. Again, it helps modulate the tone. It dampens spasticity. We could do aquatic therapy. So, in our center, we do aquatic therapy. They can do gait training. They can do exercise in water in a safe and comfortable environment, so they can focus on activating movement patterns and other complementary and alternative treatments. You could have acupuncture, acupressure, dry needling, and hippotherapy. Hippotherapy is like when you ride a horse. Okay, so I don't know if anybody is familiar with that or not. So let's go to pharmacologic management. So there are a lot of oral medications, and these medications are designed either to increase the inhibition so that you won't be too hyperactive, or they, not increase, sorry, I misspoke. They increase the inhibition or they decrease the excitation. So you might be very familiar with baclofen. Baclofen is actually our first-line drug. Common side effects are sedation, drowsiness, constipation, poor muscle tone. Tizanidine is another one of my favorites. Again, it has the same side effects. But for the next two, the tizanidine and the dantrolene, I end up monitoring their liver function tests, especially with dantrolene. It's a black box warning, so when the FDA gives a black box warning, it does denote that there's significant potential for having an adverse side effect. For dantrolene, that's hepatotoxicity or your liver, elevation of your liver function test. So usually what I would do is I would monitor your liver function tests. If I have to start dantrolene, I'll monitor it at baseline and 1 month and every 3 then 6 months. Dantrolene, though, it's not one of my favorite medications because compared to baclofen and tizanidine, which are more centrally acting, baclofen acts directly in the muscle. So my concern is I have to be judicious about who am I going to use this for, because if you already have partially weak muscles, when I give the dantrolene, this could exacerbate the weakness and not just the tone. All right. Then you have clonidine, gabapentin, and diazepam. I try to shy away from diazepam, especially in my individuals who are older because of known effects for cognition. All right, so chemodenervation. We do Botox a lot, okay, and phenol and alcohol. I'm sorry I have to slide through with this one. That's me doing Botox injections. I do it for if it's only one muscle, a focal spasticity, I would end up doing that. Intrathecal baclofen, it's an implantation of a pump that is with a catheter that is threaded into your spinal canal. So it delivers baclofen to directly bathe your spinal cord. The amount of baclofen that is given is very, very small compared to oral baclofen. But this requires a lot of commitment also from the family members, because I have to see you periodically to refill the pump or if we need to make any adjustments. Now, surgical management, we have tendon lengthening. Yeah, so if it's a very tight muscle, they do nix, so you can dorsiflex the muscle. If that doesn't work, they can do a tenotomy, where they cut the spastic muscle, or they split the muscle and do a tendon transfer so the pull isn't too much. Neurotomy is they transect the nerve that is powering that muscle. Okay, so for example, if you have spastic adductors, your legs are crossing, they would cut the nerve that's powering those muscles. Or selective dorsal rhinozotomy, this is really quite invasive. They cut the back roots, the dorsal roots of your spinal cord, where all of the sensory climbs up to get to your spinal cord and brain. Marijuana, controversial. In a nutshell, limited evidence. Sativex, which is used in MS, is not available in this country. The only things that are available in this country are dronabinol and nabilone, but they're usually used for chemotherapeutic agents. For nausea and vomiting, and those have chemotherapy. Usually, it is a last resort because of federal regulations, and it's different in different states, so I really can't address like dosaging for this because we really don't study, really haven't really studied as much about what's safe dosage for marijuana. Okay, all right. So most important thing, if I can have 1 more minute, what to talk with your doctor. This is what I would like you to bring to your physician, those of you who have spasticity. In your regular checkup with your doctors, you check about goal setting. Review what your bladder and bowel program is. Is it still working? Are you having problems? Do your regular skin check. Tell your doctor if you have a change in spasticity, sensation, strength, or function. You have to review the medications and interventions that you have been doing so far. Is it still working? Is it no longer working? If you're on those medications that I mentioned that need monitoring liver function tests, you do so at your checkup. And then also check the condition of your durable medical equipment, splints, casts, wheelchairs. Episodic care. So again, I mentioned earlier, spasticity may and will change over time. You might have to review if there's a need to change your medications, treatment, look for triggers. And then for females who are considering pregnancy, I would strongly recommend preconception counseling, meaning we have to go over the effect of your medications, potential effect of medications on your pregnancy and the fetus and breastfeeding. And that's it. All right, thank you very much. I am free to answer questions later, and I will give the next talk directly to Dr. Sadowski.